Okay, everyone. Good afternoon. My name is Leslie Hoffman. I'm the Deputy Commissioner for the Department of Medicaid Services. And on behalf of our department, we welcome you and thank each and every one of you for your participation in the forum today. This is very exciting. DMS will be providing an update on Kentucky's Section 1115 demonstration and the department's intent to request from the Center for Medicare and Medicaid Services an amendment to the current 1115 demonstration. Kentucky intends to submit an amendment request to expand services to all individuals with serious mental illness and health-related social needs to CMS by May the 31st of 2023. There has been extensive discussion, collaboration, networking, and researching, all in preparation for this request. And we are excited about the potential for the expansion of these new services for Kentuckians. At this time, I will turn over the presentation to Jody Allen, who is a lead on this initiative, and she will be sharing information with you specifically about this 1115 amendment request. Jody?
Thank you so much, Deputy Commissioner Hoffman. Good afternoon. I'm Jody Allen, Behavioral Health Specialist with the Department for Medicaid Services. And as she said, I am the lead for the SMI 1115 waiver project. Have been on board close to 2 years now, and lots of collaboration, lots of research, discussion, consideration has gone into this waiver application. So we're really, really excited to share what we have with you today. A little bit of housekeeping before we get started. First of all, wanted to make sure that you all were aware that this is being recorded per CMS's guidelines. We recorded our public forum. Please put your name, organization, and contact information in the chat for attendance purposes today. To avoid distractions and accidental noise issues, your microphones are set to mute for today during the duration of the presentation. Kentucky DMS is conducting a public comment period to receive feedback regarding the state's proposed amendment application. The public notice and draft of the extension application can be found on the DMS website under the public notice section. Please see the information displayed in the chat box regarding the comment process throughout today's presentation. We're going to go ahead and let you know how to do the public comment, and we'll also review it at the end of this presentation. Comments regarding the application in today's forum may be entered into the chat box today during this presentation. Comments and questions following today's forum can be submitted to the dms.issues@ky.gov mailbox with subject line 1115 amendment comments. Written comments must be postmarked by May 5th and should be mailed to Kentucky Medicaid Section 1115 comment, care of DMS Commissioner's Office, 275 East Main Street, 2E, Frankfort, Kentucky 40601. All comments should include a contact person, contact agency if applicable, and contact information including email address. All comments shall be submitted no later than May 5th, 2023. Following the comment period, all comments and questions will be addressed. Responses will be posted to the DMS website under the public comments section prior to submission of the application. Again, all of this information is posted in the chat box and will be refreshed periodically throughout the forum today. So at this time, let's go ahead and begin the presentation. All right, our objectives for today are to be informed of Kentucky's 1115 amendment request to improve health outcomes for individuals with serious mental illness and health-related social needs. Also, an objective is to be informed of the public comment process prior to submission of the official application in accordance with 42 CFR 431.08. So what is an 1115 amendment? An 1115 waiver amendment is often described as a pilot or demonstration project that's likely to assist in promoting the objectives of the Medicaid program. The purpose of the demonstration is to give states additional flexibility to design and improve their programs. An 1115 demonstration project presents an opportunity for states to institute reforms that go beyond just routine medical care and focus on evidence-based interventions that drive better health outcomes and quality of life improvement. So really basically a pilot demonstration where we can just take a look at how we're providing services and fiscally what that looks like, trying something new, most of the time outside of regulation with permission, and just seeing if this is something that provides better health outcomes for our beneficiaries, but also benefits CMS and DMS. Our current 1115 demonstration components under the Kentucky Health, which is the Kentucky Helping to Engage and Achieve Long-Term Health 1115 Authority. That's the overarching authority in Kentucky. It's the authority for the delivery of the following components. So currently in the Kentucky Health, we have the Substance Use Disorder 1115. We have the waive of non-emergency medical transportation for methadone treatment. We have eligibility for out-of-state former foster care youth and alignment of employee-sponsored insurance open enrollment dates. So again, we are proposing an amendment to this authority to enhance and expand services for individuals with SMI. These are the new proposed 1115 comments. I'm going to go ahead and read these word for word as they are repeated through our waiver application so that you all can know exactly what we are requesting. The first one is to reimburse medically necessary short-term, defined as statewide average length of stay no longer than 30 days, inpatient treatment services within settings that qualify as institutions for mental diseases or IMDs for Medicaid eligible adults with serious mental illness, SMI. DMS is referring to this component as IMD expansion. So that's what we're going to be calling that throughout this presentation today. The second proposed component is to implement a pilot program to provide health-related social needs services, specifically recuperative care services, also known as medical respite care, which we'll go over a little bit more later, to adult beneficiaries who are homeless or at risk of homelessness and need additional medical support and care coordination. DMS is referring to this component as the recuperative care pilot program. So again, these are the two new proposed components with this waiver, and we are calling them the IMD expansion and recuperative care pilot program. And we're going to go over those service descriptions more later. So let's talk about legislative background, some of the driving legislation for this waiver and just meeting the need. In 2021, House Concurrent Resolution 7, which is also known as the SMI Task Force, was created, and there were recommendations made to DMS to expand services for individuals with SMI, along with other recommendations across the state for ways to improve and enhance services. In 2022, Senate Joint Resolution 72 applied directive for DMS to apply for a waiver to expand supportive housing, supportive employment, and medical respite services. As you can see, we are including the medical respite services in the 1115 waiver. In our draft that is posted online, we go into a little bit more detail about the supportive housing and supportive employment components that will be addressed in a different way. So you can read a little bit more about that in our draft. But the medical respite is what we're focusing on in our 1115 public forum today. Also, we refer to KRS 210.052, which defines mental illness. And you can see that there, the definition, and the KRS 210.0053, which defines what chronic mental illness is. In addition to this KRS, we also refer to regulations within our behavioral health in Medicaid for TCM SMI individuals. So in addition to legislative efforts that are pushing us forward with this initiative and with this, we also wanted to share a little bit about what's going on in the continuum of care for SMI population in our state. I just want to stop here for a second and say I am so proud of Kentucky in all of the ways that we are caring for individuals with SMI, from services that are reimbursable by Medicaid, provider types, grant funding that's being utilized specifically for SMI individuals across the state in a variety of ways, initiatives that are taking place right now. And I'm going to give a few examples of those, but there was no way that I could possibly capture all that's being done across our state in the continuum of care for the SMI population. So I'm just really proud to be here and to be a part of this work and just to continue to push forward and expand. So let's talk a little bit about the behavioral health services first. So these are services that are Medicaid reimbursable. In 2014, Kentucky expanded Medicaid and has since broadened overall access to behavioral health services. There are many state plan covered services for beneficiaries with SMI, ranging from individual services to community supports among outpatient settings and then more intensive settings. A full list of our Medicaid state plan services can be found on the DMS website and also within our state plan for Medicaid. I'm going to give a few examples here of the services. This is not all the services that Medicaid provides, but these are maybe more specifically geared towards the SMI population. We've got individual psychotherapy, family therapy, peer support, on to more comprehensive community supports, assertive community treatment, intensive outpatient treatment, partial hospitalization, residential crisis stabilization, all the way up to psychiatric hospital inpatient. So we have a whole gamut and array of services that are available, but as we know, there are still gaps in services and provision. Medicaid provider types. So providers can enroll with Medicaid in a variety of ways for behavioral health service provision. Again, this isn't all of our provider types, but just a few of examples of provider types that are specifically geared towards the SMI population. Our community mental health centers, or CMHCs, behavioral health service organizations, BHSOs, certified community behavioral health clinics, CCBHCs, which are the more integrated behavioral health and physical health and medical, individual practitioners, behavioral health multi-specialty groups, psychiatric hospitals, residential crisis stabilization units. So Medicaid has a variety of provider types that can provide services to individuals with SMI and beyond across a continuum. Also within Medicaid, there are initiatives that are going on right now that are relevant to SMI in many ways. And again, there's no way that I can capture all of the initiatives in Medicaid and beyond that are taking place right now, but I'm going to go over a couple of these for us. The Mobile Crisis Intervention Services implementation. Kentucky DMS received funding for a 1-year Mobile Crisis Intervention Service Planning Grant, which was completed in 2022. And the goal of the implementation was to increase behavioral health preparedness for complex and high acuity individuals like those with SMI and decrease the overuse of law enforcement responding to behavioral health crisis calls. So really just finding a better way to train individuals to work with those more high acuity individuals that have more complex needs, and also to decrease some of those barriers for those individuals. Also, the CCBHC demonstration is currently ongoing. In August of 2020, Kentucky was selected to participate in the CCBHC demonstration to improve overall health by bolstering community-based mental health and addiction treatment and advance behavioral health care to the next stage of integration with physical health care. So within CCBHCs, they will provide care regardless of the ability to pay or place of residence. They provide care for those who are on Medicaid, underserved, homeless, have low incomes, or are insured and uninsured. So again, this removes some of those barriers to the accessibility of care and that integrated comprehensive care that is so needed with high acuity individuals. Also, our Racial Equity Action Plan is an initiative that's relevant to SMI. In 2021, a charter was established within the Cabinet for Health and Family Services to enhance racial equity, and the Cabinet established a Racial Equity Community Practice Work Group. DMS identified champions to serve on the work group and racial equity core team across all divisions of DMS to create a collective racial equity action plan to enhance racial and health equity and to decrease racial and health disparities across Medicaid. This work specifically targets individuals with SMI who have an increase in health-related social needs and limitations in access to services due to impairment in their daily functioning and difficulty with that executive functioning work. Other state initiatives. So again, there's no way I could capture them all, but these are a few that the Department for Behavioral Health and Developmental Intellectual Disabilities, or DBID, initiates or initiatives specific to SMI. Again, DBID receives federal funding and grants through SAMHSA, and then they disseminate those federal funds to certain and allocate to certain services, programs, and so it's a wonderful resource for for people in our state as well. But the iHope program is an early intervention program for individuals with first episode psychosis. So really just helping those individuals when they first find out that they're dealing with a diagnosis, and it helps their families too to secure services and supports. The DIVERTS program, which stands for Direct Intervention Vital Early Responsive Treatment System, through DBID and through the CMHCs. The DIVERT services are developed and made available to assist persons with SMI in transitioning to living in integrated settings in the community while receiving appropriate evidence-based treatment and support services. So really, providing those evidence-based treatment to fidelity to individuals that really have those high acuity and complex needs. Projects for Assistance in Transition from Homelessness, the PATH program, supports the delivery of services and resources to individuals who have SMI and may include other co-occurring substance use disorders and homelessness or at risk of homelessness. So this is specific to individuals with SMI and homelessness as well. Again, there were many more, but these were a few examples. A couple of other state initiatives. The Health and Housing Work Group, which is an in-state housing collaboration that was established following another collaboration. This group consists of individuals from DBID, DMS, Kentucky Housing Cooperative, the Center for Supportive Housing, and the Department for Aging and Independent Living. And the focus of this group has been to enhance the support services and processes that are available to homeless Kentuckians. Also, a focus that has been a part of this work group is a matched population within Kentucky of individuals who are homeless and who are Medicaid beneficiaries. So we took the HMIS system and the MMIS systems, and we were able to compare data within our systems and really see the numbers of where we are with homelessness and Medicaid, especially in the behavioral health area. So we were able to see a little bit more specifically about the prevalence and outcomes for this population in Kentucky. So that has really been an amazing work group, a hardworking work group over, and really has pushed us forward with our services that we're looking at and regulations, etc. Also, we have worked with recuperative care services, service providers in Kentucky. So Kentucky has several recuperative care providers across the state that address the needs of homelessness individuals requiring acute care for recovery. So as part of the waiver application process, DMS collaborated with current operating medical respite programs across the state to help inform the service provision model. So, we were able to actually use that information in our collaborations discussions. Boots to the ground, know what's being provided in our state to be able to move forward with the recuperative care model that we're looking at for DMS. Okay, so we have discussed legislation. We've discussed the overview of the continuum and what we're currently providing. We've discussed a little bit about what we're looking at providing, and now I want us to get into the new proposed 1115 amendment program descriptions. So again, as a reminder, we're looking at the IMD expansion and the recuperative care pilot program. And I'm going to take a little sip of water. Okay. The IMD expansion, we are looking at offering these services to the Medicaid beneficiaries 21 to 64 years of age. The beneficiary must meet criteria for a serious mental illness in Kentucky, inpatient treatment for mental health within a facility that qualifies as an Institute for Mental Disease, or an IMD, which is a facility with greater than 16 beds. So again, that is the setting that we're looking at for increasing the inpatient treatment setting, inpatient treatment for mental health within an IMD, which is greater than 16 beds, up to a 30-day stay statewide average per beneficiary. IMD expansion will begin immediately after CMS approval of this amendment application. Here's our rationale, or some of our rationale. There's more in our draft, and you're welcome to review our draft that's also posted. So the rationale for the IMD expansion is that Kentucky does not currently reimburse more than 15 days in a calendar month for inpatient treatment for mental health and IMDs. As you all are aware, we recently increased the days for SUD. So this would be a similar process or a similar service. So Kentucky does not currently reimburse for more than 15 days. Additional days would provide more time for beneficiaries with SMI to receive treatment aimed at stability of symptoms prior to discharge. Additional days treatment will provide more time for beneficiaries with SMI to receive more comprehensive care coordination and to address health-related social needs prior to discharge. So our hope is that those extra days will also allow some time for those individuals to secure more services and more community support services while they are in treatment. DMS proposes that a longer length of stay for acute inpatient treatment will decrease unnecessary emergency department visits and hospital readmissions. So if we can really take that extra time to provide care coordination and stabilize symptoms, and monitor and observe, that our hope is that that would prevent those readmissions that oftentimes do occur because of the short length of stay. So IMD expansion, hypotheses, and evaluation. We decided for the purposes of our public forum today to just focus on the goals. You can look in our draft and see our hypotheses and our data sources, a little bit more specific information about that. But our goals for the IMD expansion are in accordance with the CMS State Medical Director Letter 18011, opportunities to design innovative service delivery systems for adults with serious mental illness or children with serious emotional disturbance. So that is where specifically where our goals are derived. An independent evaluator will be monitoring goals and objectives for this demonstration, and more information can be found in the application draft posted online. Goal number 1 for the IMD expansion that will be monitored is to reduce utilization and lengths of stay in emergency departments among Medicaid beneficiaries. Goal number 2 is to reduce preventable readmissions to acute care hospitals and residential settings. Goal number 3 is to improve availability of crisis stabilization services, including services made available through call centers and mobile crisis teams, intensive outpatient services, as well as services provided during acute short-term stays and residential crisis stabilization programs, psychiatric hospitals, and residential treatment settings. Goal number 4, improve access to community-based services to address the chronic mental health care needs of beneficiaries with SMI, including through increased integration of primary and behavioral health care. And goal 5, improve care coordination, especially continuity of care in the community following episodes of acute care in hospitals and residential treatment facilities. So we talked about the IMD expansion, the basic criteria, talked a little bit about the goals, how the proposed goals and how they would be monitored. So a lot of us know what recuperative care or medical respite is, but I know some of us do not on this call, so I wanted to give a quick definition, and this comes from the National Institute for Medical Respite Care. We actually consulted specifically with the National Institute for Medical Respite Care as we were doing work to prepare for this waiver application. And I have the website down here if you'd like to visit that website and learn more about medical respite. Medical respite care, aka recuperative care, is acute and post-acute care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the streets or in a shelter, but who do not require hospital-level care. Unlike respite for caregivers, which is the term that a lot of us know in Kentucky, medical respite is short-term residential care that allows individuals experiencing homelessness the opportunity to rest, recover, and heal in a safe environment while accessing medical care and other supportive services. Medical respite care is offered in a variety of settings, including freestanding facilities, homeless shelters, motels, and transitional housing. So if we think about a homeless individual who has a surgery, an emergency surgery, maybe they have an appendectomy with complications, and the individual has their surgery and that really acute post-surgery care at the hospital, but now they're ready for discharge. Recuperative care will allow a place for this individual to go that has food and nourishment, that has shelter, that has clean water, that has supplies that they need in order to heal and recover before they are either discharged back to a shelter, or hopefully during this time, our hope is as well that they will receive some community support services and get the ball rolling on some of those transitional housing and supportive housing types of services. So that is what recuperative care is in a nutshell. I just wanted to make sure that that was pretty clear before we move on to what we are looking at for recuperative care for the pilot program with DMS. Our rationale for recuperative care pilot program in Kentucky Medicaid does not currently cover recuperative care services as part of the Medicaid state plan. SJR 72 has directed DMS to apply for a waiver for medical respite. Current research indicates positive health outcomes for beneficiaries when health-related social needs are addressed. Current in-state providers do not have adequate funding to expand services to meet the current needs of individuals. DMS proposes that providing recuperative care services will decrease emergency department visits and hospital readmission rates post-discharge for beneficiaries and will improve health outcomes while decreasing expenditures. So let's take a look at the eligibility criteria that we're proposing for the recuperative care pilot program. Medicaid beneficiaries who are 18 years of age and older, beneficiaries who are homeless or at risk of homelessness who meet that criteria based upon definitions in 24 CFR 91.5, and beneficiaries who are at risk of hospitalization and or readmission with a medical or other care need. Following discharge from acute care facility or emergency department, or have a planned medical procedure requiring preparation care, or have a planned medical treatment like chemotherapy treatment requiring care prior to or following the treatment, and they must have a primary medical diagnosis. They can also have a behavioral health diagnosis, but there must be a primary medical diagnosis for individuals to receive the recuperative care services. So not only does it apply to aftercare, but if there are individuals who are homeless and they meet the criteria and they have a planned colonoscopy requiring preparation care, that's an example. Or again, the chemotherapy is an example of that as well, a treatment protocol that requires care prior to. So at minimum, we are proposing that recuperative care pilot programs have the following service components. Some of these, and I just want to stop here for a minute and explain that through the National Institute for Medical Respite Care, there are 4 models of care. They go from a very basic standard, providing the minimum, to a fully integrated program of care. So when we talk to the providers across the state about what is currently being provided. We look at the National Institute for Medical Respite Care and have consultation, and we think about the services that these individuals really need and the fidelity of services that these individuals really need. So all of that has been considered as we have talked about in creating these criteria and the components. 24-hour staffed program, 3 meals a day, arranged transportation to any and all aftercare appointments. So that's arranged transportation. Access to a phone for telehealth and/or communications related to medical needs, a safe and secure space to store personal items, wellness check at least 1 time every 24 hours by a medical professional, a safe and secure, preferably double lock space to store medication in a patient's room, a nursing assessment within 24 hours of admission, medication monitoring supervised by clinical staff, on-site or access to community behavioral health services for behavioral health screening and brief intervention and referral as needed. Care coordination plan to be completed within 72 hours of admission, on-site care coordination, and required trainings for clinical and non-clinical staff. Here are the settings, the proposed settings that we're looking at for recuperative care. Interim housing facilities with additional on-site support, separate units of shelter beds with additional on-site support, converted homes with additional on-site support, Some of the limitations that we are looking at for the proposed recuperative care pilot program. DMS proposes to reimburse up to 20 beds per program at any given time to provide up to 45 days of service or care per beneficiary. 20 beds per program per day, up to 45 days of service per beneficiary. Providers interested in the pilot program must already be established programs currently providing recuperative care services in Kentucky. Providers interested in participating in the recuperative care pilot program will be expected to adhere to the proposed service components outlined by DMS for recuperative care. And prior to participating in the pilot program, providers are expected to be listed on the provider directory through the National Institute for Medical Respite Care. The time frame for this. Kentucky proposes to implement the recuperative care pilot program 1 year following the approval of this amendment. The demonstration is projected to occur over a 5-year time frame. Here are some of the goals that we're looking at for recuperative care. And again, the hypotheses and some of the more detailed information can be found in the waiver application draft that's posted online. Goal 1, reduce utilization of avoidable high acuity healthcare services through improved access to other continuum of care services. Goal 2, reduce health disparities by improving beneficiary physical and behavioral health outcomes. Goal 3, reduce health disparities by improving access to community-based services to address health-related social needs. And Goal 4, ensure long-term fiscal sustainability of recuperative care services. So we've talked about the specific services and the criteria and the eligibility for those specific services that we are proposing for the waiver. These next slides are about the overall 1115 demonstration eligibility for Medicaid. I'm not going to read these 2 paragraphs to you, but we have broken down in the presentation the eligibility information for you for the IMD expansion and the recuperative care pilot program. But the main point is that no Medicaid eligibility changes or modifications to the current Medicaid fee-for-service or managed care arrangements are proposed through this amendment. All enrollees will continue to receive services through their current delivery system. Additionally, payment methodologies will remain consistent with those currently approved in the Kentucky Medicaid state plan. If we look at the demonstration eligibility a little bit further, only these eligibility groups within Medicaid outlined in the table below will not be eligible under the proposed waiver as they receive limited Medicaid benefits, are in receipt of long-term care services and supports, or do not meet the age criteria. But it again does not impact the overall Medicaid eligibility as they would not have been eligible for these services to begin with. As far as our 1115 demonstration project enrollment, the requested 1115 waiver amendment is not anticipated to impact Kentucky Medicaid enrollment over the course of the 5-year demonstration, as there are no waiver-specific eligibility criteria included. Demonstration delivery system and payment rates for services. Benefits provided under this demonstration do not differ from those provided under the Medicaid state plan. Kentucky Medicaid does not currently have cost sharing for beneficiaries, so no modifications are proposed through this waiver application for cost sharing. As far as our demonstration implementation plan, the state is aware of CMS implementation plan requirements and is already planning activities that will support successful waiver implementation. Once the key elements of the waiver are agreed upon with CMS, the state will provide a full implementation plan according to CMS requirements within 90 days of approval of the application. Demonstration financing and budget neutrality. According to CFR 431.412, 1115 demonstrations must also be budget neutral to the federal government, which means that during the course of the project, federal Medicaid expenditures will not be more than federal spending without the demonstration. The cost of services have to be less than or equal to the cost of services provided today. Basically, that we are not having an additional expenditure by providing these services through the waiver. Demonstration finance and budgeting neutrality. Again, please refer to Appendix A of the posted 1115 amendment draft for detailed analysis of the budget neutrality impact and the methodology that they used to identify our budget neutrality. You can find more specific information there. As far as CHIP allotment, this requirement is not applicable to this amendment request, as the amendment does not make any changes to the CHIP program. Also, we know that in accordance with the state medical director letter that I mentioned earlier, this waiver request is subject to a maintenance of effort or MOE requirement to ensure the authority for more flexible inpatient treatment does not reduce the availability of outpatient treatment for these conditions. So the Commonwealth has many outpatient services, provider types, initiatives like we looked at earlier to serve the SMI population, which will continue to be available to beneficiaries despite increasing access to inpatient services through this demonstration. So we've just got to show that because we are increasing our inpatient care, does that mean that we're going to decrease our outpatient care? And that is not the intention. And we've made note of that as well. So I wanted to just show you briefly the IMD expansion budget neutrality chart. So we can see the with waiver and without waiver demonstration years over the 5 years, and we can see the total expenditures. And again, this chart is in our waiver draft application, and you can look at it and find more detailed information. Also included the recuperative care budget neutrality draft. So again, with waiver, without waiver, and you can see the 5 years and the recuperative care subtotals here at the bottom. You can look at that in the waiver a little bit more closely. Demonstration proposed waiver expenditure authorities. Kentucky requests waiver of section 1902 A10B to the extent necessary to allow the state to offer health-related social needs services, specifically recuperative care for beneficiaries who meet the eligibility criteria specified in this waiver amendment application. The state requests expenditure authority for Medicaid state plan services furnished to otherwise eligible individuals who are primarily receiving treatment for SMI who are short-term in facilities that meet the definition of IMD. So that's a little bit more information about the waiver expenditure authorities. And now let's talk a little bit about public notice and comment. So again, each of these sections are straight from the application that we turned into CMS, and as part of our public forum, we need to include all of this information for you all. Make sure that you're aware of what we're requesting and how to go about making public comments. So the public notice has been conducted according to 42 CFR 431.408. The abbreviated public notice and draft of the application can be viewed on the DMS website public notice section. That is also where, so both pieces are there. The abbreviated public notice and the draft of the application are both there. For Kentucky's 1115 demonstration, we talked about the overarching demonstration, historical information. There is a link on the DMS website to the Kentucky Health 1115 demonstration as well, if you want to look at a little bit more information about that and how this amendment relates to that Kentucky Health 1115 demonstration. So let's review public comments. Comments can be submitted via email received on or before May 5th to the dmsissues@ky.gov address with subject line 1115 amendment comment. Written comments must be postmarked by May 5th and mailed to the address below there that we mentioned earlier. And prior to submitting Kentucky Section 1115 demonstration amendment request to CMS, DMS will follow guidelines and procedures according to the CFRs regarding collection, review of, and response to public comments. Each and every public comment will be considered and reviewed and responded to prior to submitting officially submitting the application to CMS. And so that is part of our process today. I know that this is a lot of information to go through in a short period of time. As always, DMS is open to questions, concerns that you have. You are welcome to email us at the issues inbox with any questions that you have. If you have comments today that you did not put in the chat during the meeting, you're welcome to submit those also by email. And we just really thank you all so much for being interested and invested in this opportunity. And we're really excited about the opportunity to expand services for individuals who just need it so badly. And so our hope is that this will be approved and we'll be able to really help Kentuckians across the board. Does anyone on my team have anything else to add to the presentation today?
Jody, I would mention that if it is a comment that's specific to the amendment that we're talking about in this forum today, it still needs to be submitted in writing to the box. So
okay, so even if it's in the chat, it
we
needs
still
to go
need
to
it.
the box.
Yeah, we
Okay.
learned that. Yeah.
I'm sorry. Thank you for
No,
clarifying
it's
that.
it's no problem.
Okay, thank you for clarifying that. Does anyone else on my team have any comments or? Okay, well, if not, again, we're here for you. If you have some questions or concerns, please reach out to us. And thank you again so much for attending our public forum today.
Thank you.